Good evening, everybody. Fertility, a challenge in cancer patients. What is interesting about this topic is here we are going to deal how fertility has become a challenge for the oncologist and the fertility specialist while dealing with cancer patients. Now, you may ask the question as to what is the basic agenda behind discussing this issue. Firstly, to know the volatile aspect of the disease. Secondly, it is to discuss how the intersection between the cancer and reproduction has raised various ethical and legal issues in front of practitioners. And lastly, safety and efficacy of the various fertility preventive procedures practiced in such patients. I think this will help you jot down the key points you need to keep in mind while dealing with such patients. Patient's dilemma. Cancer patients are in a state of dilemma, balancing cancer and fertility. Diagnosis of cancer is a life crisis for any person. Whether it be any modality of treatment, say surgery, chemotherapy, radiation, hormones, almost all cancer patients have the potential to alter sexual function. So we can regard infertility, it is really not an easy disease to cope with. Hence, along with receiving diagnosis and treatment plan, patient must consider choices to preserve fertility. Now comes the role of the oncologist. Oncologists should be aware of the adverse effects of treatment on fertility and should suggest ways to minimize them. He should impart knowledge about options for fertility preservation procedures. The main role of the oncologist is he should stick to the most effective treatment, but on the other hand, he should not forget about the patient's post-treatment quality of life. Now comes the role of the fertility specialist. The fact that the cancer survivors have gone through the acute and extended phase of coping with cancer makes such patients different from other infertile patients. The main role of the fertility specialist is to preserve the gonadal tissue and gametes for future use. In males, this is done by cryopreservation of the spermatozoa. In females, by freezing of the egg, freezing embryo, freezing ovarian tissue. Question of fertility may also arise in minor patients who are not in a state to give consent for the same. According to the legal and ethical issues, consent, if a minor understands the situation, he can give consent. He or she can give assent for the same. Assent is a permission little less than a consent. But if the minor objects to the same, the procedure cannot be performed on the patient. But if the minor is too young even to give assent, in that case, consent of the parents or the guardians is to be taken. It is the role of the fertility experts to give proper direction of disposal of the stored gametes as to what is to be done with the gametes in future, whether they are to be discarded or they are to be used for posthumous reproduction. What actually is posthumous reproduction? If during the course of cancer the patient dies, in that case, only and only if the patient had consented that the tissue be kept for posthumous reproduction, in that case, the tissue can be handed over to the surviving spouse or the family members for its use. There are a hell lot of questions clouding the mind of cancer patients. Some set of issues include issue of offspring. The patient may feel that the offspring will be born with some physical defect, maybe due to the genetic mutation that has taken place or due to the lingering side effects of treatment. Other set of questions include if the patient plans to reproduce, in that case, there may be chances of recurrence of cancer, or his lifespan may be reduced. But preventing the birth of a child we cannot deny a cancer patient from taking a chance to reproduce. In 2006, American Society of Clinical Oncology laid down certain guidelines for the oncologist in which they described the available methods for fertility preservation and related issues in people treated for cancer. The degree to which the oncologist adhere to these recommendations is still not clear. Fleming developed a community oncofertility program called the Nichols Oncofertility Toolkit. This was named after the author's niece who suffered from lymphoma. Fleming won the AICC Innovator Award in 2011. The term oncofertility is used to describe cancer-related fertility issues. Oncofertility is every cancer patient's right and ensures that they offer the following related services. That is timely assessment of the fertility needs and desire, education about the fertility risks and options, financial and mental health counseling of the patient, quick referrals and care, ongoing and constant follow-up is to be given. What actually causes fertility in cancer patients? It may be the disease itself, the treatment side effects, the type of therapy one receives, one's age, other medications or health problems one might have, availability of the fertility preserving techniques, and last and not the least, one's religious and cultural belief about assisted reproduction. A survey was conducted by Mark Wick regarding physician-patient communication, and it found that majority, around 45% of the patients believe that doctor would be uncomfortable talking about the problem because it was sexual in nature, and 46% believe that there will be no medical treatment available for their problem. There are majority of oncofertility options available for women. To list up with, we start with radiation shielding. The reproductive areas can be shielded so that during the radiation treatment of the patient, we can plan up with conservative gynecological surgery, that is radical trachelectomy, which is done for CA cervix stage 1A and 1B. Other option is embryo freezing. It requires fertilization of the egg and the sperm and then followed by freezing of the embryo. Other includes donor eggs, donor embryos, and surrogacy, in which the woman's womb is hired, in which the embryo is implanted and she has to continue the same till birth. Traditional surrogacy includes the surrogate's egg, and gestational surrogacy includes the egg of the patient. Other experimental options for women with cancer include egg freezing banking, in which the eggs are freezed prior to fertilization. It costs around $20,000 to $35,000 per cycle. Ovarian suppression is another method in which the GnRH analogs are given to suppress the ovaries during chemotherapy. Ovarian tissue freezing. This is actually a surgical procedure in which the ovaries or the ovarian or a small part of the ovarian tissue is removed and is stored for later use and is reimplanted after the treatment of the patient has been completed. Cryopreservation of the embryos. It is actually a very reliable method of preservation of fertility. Around 20 to 30% pregnancy rates have been per transfer of 2 to 3 embryos have been reported. In this, the fertility specialists give medication to the patients and the ovaries are stimulated to produce the mature eggs. Mature eggs are retrieved and fertilized with the sperm, and the embryo formed is stored for future use. It is actually This procedure actually requires medical stability, time, partner, and adequate ovarian tissue. It is really expensive. Ethical problems may arise if the patient dies. Oocyte cryopreservation. Oocyte cryopreservation is actually an experimental method. It is technically very difficult. In this, the oocytes are rested in meiosis stage, which are extremely sensitive to temperature changes. Crystal formation may occur and cause cytoplasmic damage. The cryoprecipitants used may cause depolarization of the meiotic spindles, cause aneuploidy, hardening of the zona pellucida, or may act as a barrier to fertilization. Cryopreservation of ovarian tissue. This again is an experimental investigational method. It requires a surgical procedure in which ovary or piece of ovary is removed. The cortex is frozen into slices. Primordial follicles, which are less sensitive to cryo damage because of the low metabolic rate. In ovarian cryopreservation, after the treatment of the cancer patient has been completed, the tissue can be reimplanted at any heterotopic site, which may include, here in this slide, we can see it has been implanted in the forearm of the patient. The advantage of this procedure is there is no need for any abdominal surgery. Easy monitoring of the follicle can be done, and if necessary, it can be removed very easily. The only disadvantage of this procedure includes that there are chances that we re-implant the malignant cells back into the cancer survivors. Oncofertility options for men include radiation shielding, sperm banking. Other options include donor sperms, and experimental options include testicular sperm extraction and epididymal sperm aspiration. In the end, I conclude here as fertility in cancer patients is really very complex and emotionally volatile issue. So a planned, coordinated way to address complicated medical, ethical, and legal issues of the patient is to be done. Centers should recognize the importance of this in younger cancer survivors too. Fertility specialists should be referred at the earliest possible. There should be law which could recognize the offspring, especially the posthumous of the stored gametes, as natural legitimate child of the deceased, and in the event of pregnancy should consider high-risk obstetrical management. Thank you.